So I'm going to present you the procedure of percutaneous gastrostomy under fluoroscopy guidance. Our patient is a woman. She's 49 years old, and she suffers from a squamous and oropharyngeal squamous cell carcinoma, as you can see here. And she will be treated with surgery, chemotherapy, and radiotherapy. So in order to prevent some denutrition after the treatment, we are going to place in her stomach a gastrostomy. That's a so-called a gastrostomy for nutrition support. There is another indication of gastrostomy. It's so-called a decompressive gastrostomy, and it's reserved to patients with advanced malignancies with chronic intestinal obstruction. So I'm going to present you percutaneous placement of gastrostomy under fluoroscopy guidance. We place a gastrostomy for example, for patients with head and neck cancer or very advanced malignancies. The patient must be perfused to inject glucagon, intravenous glucagon during the procedure. So the patient must be fasted overnight in order to minimize gastric residue. And then we are going to place a nasogastric tube in order to perform the gastric insufflation that is needed for the gastrostomy placement under fluoroscopic guidance. Placing lidocaine on my catheter. So you can see under fluoroscopic my guide wire. And I will ask the patient swallowing. Ouais, essaye d'avaler. Okay. So we can see in AP view that I'm not in the trachea. As you can see, the catheter is now in the stomach. So the final step of the patient preparation is an ultrasonography in order to mark the left liver lobe in order to avoid its puncture during the procedure, because some patients can present hepatomegaly. I will make a cutaneous mark of the left liver lobe. So I will present you our introducer kit. We have the Kimberly-Clark introducer kit. So it's composed by 4 preloaded T-fasteners. Inside the needle, there is a preloaded T-fasteners. And when I will be inside the gastric lumen, I will release the anchor inside the lumen. The T-fastener is linked with a resorbable suture, and at the end of this suture there is a lock button. This clamp will be useful to lock the button. Then we have a serial dilatator, and the last dilatator is a peel-away sheath. Through this peel-away sheath we will put the gastrostomy tube. There is a bistoury and another needle, and this final needle will follow the final track of the gastrostomy tube. We have a J guide wire. For the local anesthesia, we will use 1% lidocaine mixed with ropivacaine. In order to obtain the perfect gastric distension, we will inject in intravenous way smooth muscle relaxant That's glucagon, 1 milligram. And 3 minutes after the injection, we will perform air insufflation of the stomach in order to obtain a gastric distension. The gastric distension is very important to displace, for example, the colon, because I want no structure between the skin and the entire stomach wall. So we will now inject room air into the nasogastric tube in order to perform the gastric distension. You can inject in a stomach 500 millimeters. So we've now injected 50 milliliters of room air, and there is now a good distension of the stomach. The intended place of the gastrostomy tube, in order to prevent arterial injury, is mid to distal body of the stomach, equidistant from the greater and the lesser curvature. But before placing my gastrostomy tube, I will perform the so-called gastropexy. The gastropexy is used to fix the entire wall of the stomach just under the skin. I want to place my gastrostomy tube here, and so I will place 3 T-fasteners at each corner of triangles, and each corner is above, at a distance of 2 centimeters of the center of the triangle. So I will now inject the local anesthesia. So at each moment, you can realize another injection, another insufflation in the stomach. And now you can see under fluoroscopic guidance the needle approaching of the entire wall of the stomach. Now on the fluoroscopy, you will see the first sign that is needed to be sure that the needle is inside the lumen of the stomach. So we will see under scopic guidance the perforation of the entire wall. Here you can see I can push away the entire wall of the stomach, and now I made the perforation of the stomach. The second sign is with gently aspiration. I have some air in my syringe. So if I were in the peritoneum, it will not happen. And the third sign is injection of contrast media that will outline the gastric folds. So I'm sure I'm in the lumen of the stomach, and I can release the T-fastener. With this manipulation, the T-fastener is now inside the lumen. So I will release the suture, and now there is 1 T-fastener placed in the lumen of the stomach. We can now place the second T-fastener. On fluoroscopic guidance, we can see the perforation of the entire wall. I have some hair in my syringe, and contrast media outline the gastric folds. I'm now sure I'm in the lumen of the stomach, and I can release my T-fasteners. It's important to not lock the first one and the second one T-fastener, because if you do that, the entire wall of the stomach will already be fixed under the skin, and so you can miss this sign because you have already fixed a part of the entire wall of the stomach. And that's a little tip for some patients, for example, with hepatomegaly, or for patients who have stomachs very high in the thorax. sometimes it can be useful to use the ultrasonography guidance in order to guide the first part of the track of the needle. That's why I'm going to show here an ultrasonography. You can see my needle approaching of the entire wall of the stomach. Now I'm sure I'm just in front of the entire wall, and you can check that under fluoroscopy, I'm just in front of the entire wall, and there is the perforation. So we now have 3 T-fasteners inside the lumen of the stomach at each corner of a triangle, and I can now lock the button. The entire wall of the stomach is now just under the skin, and I can, with a gentle traction, fix and lock the button. One tip for this step is to make a skin incision large enough to pass the future gastrostomy tube. So with this needle, I will take the final track of the gastrostomy tube. Usually, we take the direction of the fundus, but if your intention is to place a gastrojejunostomy, you will have to take direction of the pylorus or the fundus. As I have explained to you, because of the gastropexy, under fluoroscopic guidance, there's a high risk of not being able to see the perforation of the entire wall. It's very difficult to see this sign because of the gastropexy, but we have the other sign. I have air in my syringe and an injection of contrast outline the gastric folds. Inside my needle, I will place the J guide wire. As you can see, the guide wire is inside the stomach. Do not release this guide wire until you're completely sure that your gastrostomy tube is within the stomach lumen. Now we have to make the dilatation of the final track. The red color means that the final dilatator is the peel-away sheath. So I will place this dilatator. And now without releasing the guide wire, I will release the dilatators. In our department, we place 16 French Maleco inside the stomach for the 6 first months. And on my guide wire, through the peel-away sheath, I will place the gastrostomy tube. I will now release the peel-away sheath. In our department, we were used to fix the gastrostomy tube with a non-resorbable suture for the first months of the gastrostomy. So at the end of the procedure, we have 2 systems of fixation. One non-resorbable suture fixes the gastrostomy tube, and the lock button of the gastropexy are fixed with resorbable button, and they will fall in a few weeks. At the end of the procedure, I can check that there is no bleeding inside the stomach. Here we have just gastric residue. and no bleeding. So the gastrostomy tube can be used tomorrow. The patient stay fasted overnight for 1 night. In our department, for the first 6 months, we place a mallecote, 16 French mallecotes, and after the 6 months, we place another gastrostomy tube, a balloon gastrostomy tube, which caliber is 16 French.